I'm presenting here at ASH 2018 a study looking at newly diagnosed patients treated with a KRd regimen or carfilzomib-lenalidomide-dexamethasone compared to patients treated with the VRd regimen or bortezomib-lenalidomide-dexamethasone. We are using the Commpas study, which is the initiative that was launched in 2011 by the Multiple Myeloma Research Foundation, the MMRF. Using this resource, we identified all the patients treated with the KRd regimen, and there were many more patients treated with VRd because that's an older regimen. So we took the approach of designing a nested case control design. So for each patient treated with KRd, we identified a matched control with a propensity scoring approach. And then we looked for clinical outcomes. The main results show that the event-free survival is highly significantly superior for patients treated with KRd. The hazard ratio is 0.35, so it's a 65% reduced risk of the adverse outcome in the KRd patients. The study had about 150 with KRd and about the same number, 150 with the VRd, because it's the matched nested case control study. Because this is not a clinical trial that is randomized, this is a cohort study using the Commpas study as the resource. So you identify the first group for cases, this is the KRd regimen, and then you look within the database to see how you can find matched controls, which is the VRd patients. So therefore, there is no capturing every cycle by a protocol. These are patients from the real world around the world. So what we had to do in order to get a better understanding of toxicities, we decided to look at adverse events that resulted in discontinuation of the treatment. And I think it's important to say that in this real-world resource from the Commpas study, the adverse events that resulted in discontinuation of therapy was very, very low, so around 2%. And it was virtually the same for the two treatment arms. So the conclusions of the study is looking at event-free survival using Commpas study as the resource, that the KRd regimen is highly more superior in terms of progression-free outcome. This is measured in event-free survival, so that means that the risk both of progression, the risk of death, and the risk of having to change therapy. That's the information that goes into event-free survival. It's highly superior in KRd. It's actually 65% reduced risk compared to the VRd regimen. I think it's important to say that this is not a clinical trial. If you stick to the standard approach for validation of what data is going forward, we should probably wait and see what a randomized prospective study will show. And there is actually an ongoing study here in the United States comparing the KRd regimen with the VRd regimen. This was funded by the National Cancer Institute, so this is a federal funded study. In addition to the main message that the event-free survival is highly significantly better for KRd, a hazard ratio of 0.35, we also look to see if patients were transplanted after the combination or if they were not. And then we conducted stratified analysis. And the message and the information from the study is that the hazard ratio is virtually the same if patients receive this combination KRd and a transplant or VRd with a transplant. The hazard ratio is again in favor of KRd. If patients were not transplanted, same thing applies. The hazard ratio is strongly in favor of the KRd regimen.